Everybody has a favorite part of the process, and for me, it's the visualization aspect of doing this kind of dentistry. And one of the things that I would strongly recommend is that when you're going to be going down this road and start doing these type of cases, you want to set up a little place in your office where you're going to be comfortable and where you can sit, that you've got a waxer and an ability to look at a computer screen for your photographs, a lab engine so you can adjust models, and just be comfortable and organized. We are at the Bayview Dental Lab today and doing it in a lab situation, but back in my practice, we have an area where it's the staff's responsibility to organize the models and keep everything straight for me. And I have a time slotted every day to do this, and for me it's early in the morning when I first get there. What you're going to want to make sure is, again, that you have really good data, that you've got a nice clean set of mounted models, that you've got your photographs that are either going to be in the computer, or in this case they'll have been loaded into the diagnostic wizard. You want x-rays, you want probings, you want your full restorative charting so that we can go through this. Now, the key in this type of visualization is that we're going to start with just creating a problem list, looking at the global things first, the global things that are wrong. So we're going to be looking at functional issues that may be present and aesthetic issues that may be present. And then we'll start going to the tissues and to the teeth themselves. But I think the mistakes that most dentists make is that they forget about the global aspects of this masticatory system, and they just start treatment planning what they're going to do tooth by tooth. And so we want to step back a little bit and show you the order that we visualize, beginning with our 2D checklist, and then work through the 3D checklist, and then show you how we sequence, which a case here, Cheryl, that is moderately complicated. So let's have a look. Okay, so we're at our little treatment planning bench here, and as you can see, I've got some photographs. Now again, in your office, you'd be likely looking at this on a computer or traditional. Since I've come over to the lab, I've printed this, but we want our PAs and bite wings to have a look at. We've got our probings, and this is both in a printed version as well as the graphical version here. And as you'll see in our wizard here, we've made the notations of the teeth that we've got to work on from a restorative standpoint. So what I want to do is spend a minute going through the examination, the findings, so you can bring us up to speed with what's going on with Cheryl. We'll look at the photographs, then start through the checklist here. So in terms of the preclinical screening, she came to the office, basically was interested in finding a new dentist, was concerned about the cracks on her front teeth. She has some history of crowns, broken teeth, large fillings, and what she described as soft teeth. And her aesthetic concerns initially were sort of low to medium. Wasn't really describing things to me that were really wrong. We went through the oral cancer check. Everything was normal here. No problems. We went through the 7 questions, and she answered no to all of them. No history of joint issues, popping, pain or tenderness when she opened, closed, or chew, never locked, no headaches. She doesn't grind or clench, and no history of trauma. So fairly innocuous so far. When we palpated her muscles, she did have some slight tenderness to the superficial and deep master on both sides. Everything else was clear. She had a completely normal range of motion and was asymptomatic in the joints. Again, load tested. She was within normal limits, but she did hit high over on 15 and 31 with about a 1 millimeter slide. And again, CR and MI are not the same. We went ahead and did Doppler auscultation with her, and she was quiet on the medial and lateral pole, which makes her an ideal candidate for any sort of restorative procedures. Overbite, again, overjet relationship about 4 and 3. You'll see mild crowding, but primary concern was that she definitely had some exposed dentin, 22 through 27 and 6 through 11. And she had several teeth on the left side of her mouth that were loose. Mobility 11, 12, 13, 14, 19, 20, and 21. And what was interesting is when I found those loose teeth, her comment to me was that you found my problem area. When I asked her why she didn't tell me about her problem area, she said she'd been complaining about it for 15 years and that no dentist said that there was an issue there, that there was no problem. And so I think she'd sort of given up any hope of being able to fix that. We looked at her occlusion, and we'll look at the cast here in a second, but in her mouth she had really poor stops, no guidance. She had no disclusion and protrusion, slight rubbing of the back teeth, large balancing interferences, and some working interferences as well. We'll also note that she was really hitting pretty hard on that, the left side where it was bothersome. So Dawson classification of 2, angle classification of 1, but does have some slight class 3 tendencies that we'll look at, and she bruxes. The other notation I should have made here is she's had some bicuspids, one bicuspid removed on the right side of her mouth, which throws off her midline a little bit. No night guard use, doesn't snore, never been diagnosed with sleep apnea, doesn't wear any CPAP appliances, does not have her tonsils, and her neck is smaller than 16 inches for a woman. So the Malapati score was 2, so not so bad there. And basically, from the standpoint of her skeletal relationship, we'll look at, again, class 3 type tendencies, but fairly happy with everything she's seen. And again, but in a little further explanation, she is concerned about the wear in her teeth, and she's not totally happy with her smile. She's currently about a A3, and if she was going to do something, she'd like to have it brightened up a little bit. So let's just look at some of the restorative findings on her teeth. As I mentioned, this is the 13-14 area, because we're in the mirror. This is the area that was mobile. You'll see on the x-ray we found some pretty good decay on the mesial of this tooth, the distal of this tooth, which is problematical. And then really just the wear on 6 through 11, 6, 7, 8, 9, 10, 11, an older amalgam back there on 3. And then when we look on her bottom teeth, also we look canine to canine, and she's pretty far into the dentin. So these are all teeth that we're going to make notations on that we're going to need to do something with to restore them. Doesn't necessarily mean crowns right now, but we just want to make a notation of the areas that are not cleansable or have exposed dentin as we go tooth by tooth. So what we're making a notation of then, there's no hopeless teeth, but 3, 6 through 11, 13, 14, 18, 19, 22 through 27, and 31 are all teeth that we're going to be dealing with for a variety of reasons. All right, as part of that exam, we also went ahead and did her photographs. And one of the things that's really interesting is if you'll notice that when we looked at her face just clinically, I didn't really see that many issues with midline or skeletal tendencies. And I want to show you that when we start looking closer at the photography, we sometimes pick up things that we wouldn't have seen when we're at the chair. So let's go and now proceed through our 2D checklist. Again, we're going to be starting with the very first question about whether that joint is stable or not. I've already gone through the checklist with Cheryl, so you know that question was answered. You are aware from the complete exam, no history of joint issues, joint was loadable, no popping or clicking. So good, stable, healthy joints, which means we can now focus on our occlusion.